Hi, everyone, and welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Reena, and today we're joined by Noha to dive into something fundamental but often so tragically misunderstood: the menstrual cycle and abnormal uterine bleeding.
Hi, Reena. I'm excited to discuss these topics because they come up so frequently in both clinical settings and exams. And understanding histology and hormonal control is essential to be able to answer our exams, and also, more importantly, be overall better physicians to our patients.
So, let's start with a case. A healthy 24-year-old woman comes in simply curious. She's tracking her cycles and wants to understand what her endometrium is going through each month. How would we break that down for her?
Love that for her. The endometrium undergoes cyclic changes under the influence of estrogen and progesterone. These changes happen in sync with the ovarian cycle, ranging from the proliferative phase to secretory changes and finally the menstrual shedding if there's no pregnancy.
Okay, that makes sense. But what exactly is happening in the uterus throughout the menstrual cycle?
It's the cyclic remodeling of the functional layer of the endometrium, and that's the layer that's shed. It's controlled by the ovarian hormones. Estrogen drives the proliferation before ovulation, and progesterone triggers secretory changes after ovulation.
So, how long is a typical menstrual cycle, and which hormones are our main characters here?
Typically, a menstrual cycle ranges anywhere from 21 to 35 days, so there's a bit of variation from person to person. As for the cast of our hormonal play, first there's FSH, or follicle stimulating hormone. That one's responsible for helping the follicles develop in the ovary. Then we have LH, or luteinizing hormone, which is the first one that triggers ovulation. Estrogen plays a big role in the first half of the cycle, promoting growth in the glands and stroma of the endometrium. And finally, progesterone takes over after ovulation. It encourages the glands to start secreting the stroma to become edematous, and it even initiates early decidual changes, all to support a possible pregnancy.
Wow, that's a lot. Can you walk us through the histological changes in the endometrium over the cycle?
Sure, let's go phase by phase and link each one to the hormone changes. First is the proliferative phase, where estrogen is dominant. You'll see glandular and stromal mitosis, and the glands are straight and tubular. Then comes the early secretory phase, right after ovulation. Progesterone kicks in here, and you notice subnuclear vacuolation in the glandular epithelium, one of the first signs it's active. In the mid-secretory phase, the glands start actively secreting into the lumen, and the stroma becomes soft and edematous. By the late secretory phase, or premenstrual phase, stromal cells enlarge and take on eosinophilic cytoplasm. That's the pre-decidual reaction. You'll also see the leukocyte infiltration starting. Finally, in the menstrual phase, hormone levels drop and the functional layer sheds. Microscopically, that means breakdown of the glands and stroma, vascular changes, and bleeding.
So, just to recap, during the cycle, we go from the proliferative phase, where estrogen helps build things up, to the secretory phases, where progesterone takes over and preps the endometrium, and then finally, the menstrual phase, where the functional layer sheds if there's no pregnancy. What happens if this cycle stays undisturbed?
Then everything proceeds smoothly. The functional layer regenerates every month, and the woman experiences a regular cycle. But any disruption in the hormonal control, or inflammation, infection, or structural lesion can derail the process and lead to abnormal uterine bleeding.
All right, time to quiz the listeners. Let's see who's been paying attention. What's the earliest histological sign that ovulation has happened?
Ooh, good one. The answer is subnuclear vacuolation in the glandular epithelial cells. It's our first clue that progesterone is kicking in.
All right, next up, let's talk about a case. We've got a 15-year-old girl dealing with heavy, irregular periods ever since menarche. Her lab work looks totally normal. What should we be thinking here?
That definitely sounds like an anovulatory cycle, which is actually really common in adolescents. The hormonal axis is still maturing, so ovulation doesn't always happen. And without ovulation, estrogen isn't balanced by progesterone, so you get unopposed estrogen stimulation. That's what often leads to abnormal uterine bleeding in young patients like this.
So, how do we define abnormal uterine bleeding?
It's any bleeding that is excessive, prolonged, or happens at irregular intervals. It's a symptom, not a diagnosis, and has different causes based on age group.
All right, let's break it down by age group. What are we usually looking at when it comes to abnormal uterine bleeding at different ages?
So here's how it usually plays out. Age by age. In pre-puberty, abnormal bleeding is often hormonal. Think Precocious puberty. In adolescence, the most common causes are anovulatory cycles and bleeding disorders. Once we hit the reproductive years, it's a mix of things: pregnancy-related complications, dysfunctional uterine bleeding, and structural issues like polyps, hyperplasia, or even carcinoma. In perimenopausal women, anovulatory cycles are still a big factor, but the risk of hyperplasia and carcinoma starts to rise. And finally, postmenopausal bleeding is most often due to endometrial atrophy, though it's important to rule out organic causes like polyps or cancer.
Let's dive into anovulatory cycles for a bit. They're a major cause of abnormal bleeding, especially in younger patients. So, how does an ovulatory cycle actually lead to bleeding?
When ovulation doesn't happen, there's no progesterone to stabilize the proliferative endometrium, so estrogen keeps stimulating the lining, leading to cystic glandular dilation. Eventually, the stroma breaks down unpredictably, which causes heavy, irregular bleeding. Less common causes of inovulation include endocrine disorders like thyroid dysfunction, adrenal disease, or pituitary tumors. Ovarian lesions such as granulosa theca cell tumors or polycystic ovaries, and metabolic disturbances, for example, severe malnutrition, significant obesity, or chronic illness.
What about inadequate luteal phase? How does that present clinically?
This condition often shows up as infertility, sometimes with increased bleeding or amenorrhea. Basically, the corpus luteum doesn't produce enough progesterone, which shortens or weakens the secretory phase.
Interesting. And what would a biopsy show in this case?
An endometrial biopsy performed at a post-ovulatory date would show secretory endometrium, but it lags behind what you'd expect for that point in the cycle. It's out of sync with the hormonal timeline.
So, what kind of changes do oral contraceptives cause in the endometrium?
OCPs contain synthetic or derivative ovarian steroids, and the type, dose, and delivery method all play a role in the outcome. What we typically see is a discordant appearance between the glands and the stroma. The glands are inactive, while the stroma is filled with large, cytoplasm-rich cells that mimic the decidua of pregnancy. And the good news? Once the therapy is discontinued, the endometrium usually reverts back to normal.
All right, Noha. Let's wrap up the DUB section with a look at the menopausal transition. What's happening to the endometrium during these phases?
Alright, so during menopause, anovulatory cycles are pretty common, and they lead to some structural changes in the glands. If estrogen production keeps going for a bit, you can get mild hyperplasia with cystic glandular dilation. But once the ovaries fully check out, you get endometrial atrophy. And here's a key detail. Those glands might still look cystically dilated, but it's not hyperplasia. Why? Because there's no stromal proliferation happening.
Time for a quick knowledge check. What's the key histological clue that helps you tell postmenopausal cystic changes apart from true hyperplasia?
In cases of postmenopausal atrophy with cystic dilation, the big giveaway is that there's no glandular or stromal proliferation. That's what sets it apart from simple hyperplasia.
Let's shift gears and talk about endometritis. Picture this. A postpartum woman comes in with fever, uterine tenderness, and foul-smelling discharge. What's the first thing that pops into your head?
That's a textbook case of acute endometritis. It's usually due to retained products of conception with a superimposed infection.
So, how do we define endometritis?
It's an inflammation of the endometrium. It can be acute or chronic, and each has different causes and microscopic findings.
All right, let's dig into the causes. What are we looking at?
For acute endometritis, it's usually tied to retained gestational tissue and infections with organisms like group A strep or staphylococci. Chronic endometritis, though, has a wider range of causes. You'll see it in women with chronic PID, in postpartum or post-abortion cases with retained tissue, and in IUD users. It can also show up in women with tuberculosis, especially when it spreads from the fallopian tubes. And don't forget chlamydia. It's a tricky one because it can cause both acute and chronic inflammation.
What cells do we look for under the microscope?
In acute endometritis, you'll see polymorphonuclear leukocytes in the stroma, a classic sign of active inflammation. But for chronic endometritis, the key diagnostic clue is plasma cells. You've got to see them to make a confident diagnosis.
And what's the typical approach to treatment?
For acute cases, it's usually antibiotics. And if there's a retained tissue, you may need surgical curettage. For chronic cases, Treatment depends on the cause. That might mean removing an IUD, treating TB, or addressing whatever underlying infection is driving it.
All right, pop quiz time. What's the most important cell you need to spot under the microscope to confidently diagnose chronic endometritis?
That would be plasma cells. They're the hallmark of chronic endometritis.
Next up, let's tackle a condition that often flies under the radar but causes a lot of trouble for reproductive age women. Now, say we have a 35-year-old woman with severe dysmenorrhea, painful intercourse, and pelvic pain. She also struggles with infertility. What should we be thinking?
This screams endometriosis, where endometrial tissue is found outside the uterus, causing bleeding, inflammation, and fibrosis.
What's the textbook definition of endometriosis?
It's the presence of endometrial glands and stroma outside the uterine cavity, and it shows up most often in women of reproductive age.
Ooh, and what are the common sites where endometriosis tends to show up?
Most commonly, it's the ovaries, and that can lead to those classic chocolate cysts, but it doesn't stop there. You'll also find it in the uterine ligaments, rectovaginal septum, the cul-de sac, and sometimes even the bowel or bladder. And in rare cases, it can pop up in places like the lungs or even the brain.
Oh, this part always blows my mind. How does endometrial tissue actually end up outside the uterus? What are the leading theories behind endometriosis?
It's actually pretty interesting, Reena. There are 4 main theories that try to explain it. First up is the regurgitation theory. This one's the most widely accepted. It suggests that menstrual blood flows backwards through the fallopian tubes, carrying endometrial cells with it. Then, we have the metaplastic theory. This one says that coalomic epithelium, that's the lining of the pelvic cavity, can actually transform into endometrial tissue. Next is the metastatic theory, which proposes that endometrial cells can spread through the lymphatics or bloodstream, a bit like how cancer can spread. And finally, there is the stem cell theory. According to this one, bone marrow-derived progenitor cells might travel and develop into endometrial tissue in places they're not supposed to be.
So, what does the histology look like?
Classic triad: endometrial glands, stroma, and hemosiderin-laden macrophages. But just a heads up, in older lesions, fibrosis can set in and make those features harder to spot.
Okay, let's talk about symptoms.
The most common ones are dysmenorrhea, dyspareunia, and pelvic pain. If the rectum's involved, you might see pain with defecation. Bladder involvement, that can lead to dysuria. And here's a big one, infertility, which shows up in about 30 to 40% of cases. Oh, and although it's rare, endometriotic lesions can sometimes develop into malignancy.
And what's the management approach?
Depends on severity. Options include hormonal suppression, laparoscopic excision, or even hysterectomy in severe cases. It's chronic and recurrent, but manageable.
All right, quiz time! What are the 3 classic histologic findings in endometriosis?
Glands, stroma, and hemosiderin. These are your big 3.
Okay, let's say we've got a 40-year-old woman with heavy, irregular periods, pelvic pain, and dyspareunia. On exam, her uterus feels enlarged and boggy. What's climbing to the top of your differential?
That's sounding a lot like adenomyosis, where endometrial tissue grows into the uterine muscle, also known as the myometrium.
So, what exactly is adenomyosis?
It's defined as normal endometrial glands and stroma located deep within the myometrium, at least 2 to 3 millimeters below the basalis layer. Basically, the endometrium is invading where it doesn't belong, but this time, it's staying inside the wall of the uterus.
All right, how common is this, and what's behind it?
Adenomyosis actually shows up in up to 20% of the uterus, Reena. The most accepted theory? It's the basalis layer of the endometrium going downward into the smooth muscle, and over time, that misplaced tissue starts messing up with the uterus's normal structure and how it contracts.
What would we see under the microscope?
Histologically, you'd see irregular nests of endometrial stroma, sometimes with glands, sometimes without, sitting right inside the myometrium. And here's the key detail. They're not continuous with the basalis. You'll find them about 2 to 3 millimeters deeper, which is what really confirms the diagnosis.
And symptom-wise, what do patients usually feel?
Classic symptoms include menopausal, that's irregular, heavy bleeding, plus colicky dysmenorrhea, dyspareunia, and pelvic pain that tends to ramp up before the period starts. It's definitely not a quiet condition.
How do we treat it?
Treatment depends on severity and fertility desires. Options include hormonal therapy, IUDs, or hysterectomy for definitive management.
Time for a histo spotlight. What's the hallmark finding in adenomyosis?
Endometrial glands and stroma located within the myometrium. In the key detail, they're separated from the basalis by at least 2 to 3 millimeters.
All right, let's look at our final case. A 52-year-old woman with postmenopausal spotting. Her transvaginal ultrasound shows a mass in the endometrial cavity. What are we thinking?
That definitely sounds like an endometrial polyp. It's a benign exophytic mass that projects right into the uterine cavity.
So what exactly is an endometrial polyp?
It's either a sessile or pedunculated mass, usually somewhere between 0.5 and 3 centimeters. Histologically, it's made up of endometrial glands, stroma, and blood vessels. They can show up as a single polyp or multiple, and they might be functional, atrophic, or even hyperplastic.
What causes them, and in whom do they occur?
They can actually show up at any age, but they're more common in postmenopausal women. As for causes, estrogen stimulation is a big one. Tamoxifen use is another. It can act as an estrogen agonist in the uterus, which is kind of ironic, right? And here's a cool genetic tidbit. Many endometrial polyps show a chromosome 6p21 rearrangement involving the HMGIY gene. That same marker shows up in other benign mesenchymal tumors too.
How do they develop, and how do they appear histologically?
Histologically, polyps can show a few different patterns. Some have hyperplastic glands that respond to estrogen, while others, especially in postmenopausal women, have atrophic glands. Occasionally, you'll see secretory changes if it's a functional polyp, but that's rare. The stoma is usually fibrous and may contain thick-walled blood vessels. And although it's uncommon, endometrial carcinoma can develop inside a polyp, so they're not always completely innocent.
And symptom-wise, what do polyps usually cause?
A lot of them are totally asymptomatic. But when they do cause symptoms, it's usually abnormal bleeding. That can happen if the polyp ulcerates, undergoes necrosis, or in rare cases, actually protrudes through the cervix.
And what's the standard treatment?
Most of the time, simple hysteroscopic removal does the trick. Polyps are usually benign, but if there's any sign of atypia, or if the patient has postmenopausal bleeding, they definitely need histologic evaluation to rule out anything more serious.
Let's hit one last quick check. What genetic abnormality is associated with endometrial polyps?
That would be 6p21 chromosomal rearrangement involving the HMGIY gene.
All right, Noha, this has been a full tour through the endometrium. Let's wrap things up with a quick summary.
You got it. Here's what we covered. The menstrual cycle is all about estrogen and progesterone working together, starting with glandular mitosis, followed by subnuclear vacuoles, secretion, stromal edema, and eventually shedding if there's no pregnancy. Abnormal uterine bleeding depends on age, and ovulatory cycles are common in adolescents and perimenopausal women. And in postmenopause, we always think about atrophy versus malignancy. And ovulatory cycles mean unopposed estrogen, which leads to prolonged stimulation and stromal breakdown. Inadequate luteal phase? That shows up as a lagging secretory endometrium and can cause infertility. Take it from here, Reena.
All right, so oral contraceptives create a mismatch, which are inactive glands but decidual-like stroma. In menopause, unopposed estrogen can cause cystic dilation, but it's not hyperplasia unless there's stromal proliferation. Endometritis comes in two forms, acute with neutrophils and chronic with plasma cells, often after infection or retained tissue. Endometriosis is endometrial tissue outside the uterus, explained by theories like regurgitation, metaplasia, metastasis, and stem cells. Adenomyosis is when glands go deep into the myometrium, causing heavy bleeding and pain. Endometrial polyps are estrogen-responsive growths, often linked to the HMGIY gene rearrangement.
And the bottom line? Each one of these leaves behind its own distinct histologic signature.
Noha, wow, that was a masterclass. Seriously, thank you so much for breaking all of that down so clearly.
You're welcome, Reena. I know it was a lot, but I hope it helps our listeners piece together the histology, hormones, and clinical symptoms into one big clear picture.
And whether you're a student preparing for exams or a clinician brushing up on your path, we hope today's journey through the endometrium gave you the insight you needed. Stay tuned for more episodes right here on PodBites.
Until next time, stay curious and happy learning.